Hi, good evening, everyone, and welcome to part 2 of the fertility journey. I am Yoetzet Halacha Atara Ice. I have specialization as a Nishmat Yoetzet Halacha fertility counselor, and I'm joined here with Dr. Bat-Sheva Maslow, who is a reproductive endocrinologist and the director of our medical curriculum at Nishmat's Miriam Glaubach Center, and also Dr. Karen Wasserstein, who is a psychologist who specializes in helping couples on their fertility journey. You can learn more about all three of us in our bios right down below. And meanwhile, it really is an honor because this very much symbolizes our approach at Nishmat, which is anytime we're talking about any topic, but specifically, all the more so when we're talking about fertility, we bring together all parts of the team and we talk in a holistic way. And we talk about the halacha in conversation with everything medical and everything emotional, psychological, mental, the way in which it all comes together. So it is an honor to be with you this evening. And without further ado, I would like to ask Karen to open us up and talk with us. You know, we're talking about treatment. We talked earlier today. You can listen in, and strongly encourage you to listen in to part 1, which was with Lori Novick, Yoetzet Halacha Lori Novick, and Dr. Jordy Hyman and Rhonda Desky. And now we're moving on to treatment. So I'm going to ask if Karen could open up and discuss some of the emotional aspects and challenges of fertility treatments.
Thank you, Atara. And I'm always pleased to present with Atara and Bat-Sheva. It is a really great team. As an overview of the mental health side, I always like to start with the idea that everyone comes in with their own story. Whether it's been easy or hard to achieve other goals that they've had, whether they have other supports or stressors that's really important to take into consideration, their own interpersonal relationships. Do they have people that they feel are non-judgmental in their corner? And have they ever been in need of seeing if that is so? I always talk to my clients that there's a really big difference between being needy and being in need. And we are often told it's not good to be needy, but it actually is okay to be in need and to pull on your support team and figure out how to navigate really big challenges in life. Everyone has their own family dynamics and their own in-law dynamics, their own community dynamics, their own history of physical and mental health challenges, and their own marriages. And that means that everyone processes differently and copes with this differently and needs to understand in what way this is poking on them aside from the obvious. And the mental health practitioner's job is to help them understand all of these issues. How does this interplay with your unique story and your issues? It can be a wound to your identity. Who am I now that this has changed my lens on myself, on my world? People struggle with their religion, which I know we're going to cover a little bit. When confronted with fertility challenges, trust issues with their own body, with the medical team, with their community, and how they feel out of sync. Control issues. This is often the first time people really, it's not, you can work hard and achieve. The message is very different. It's often not in your control, and what pieces are in your control and what aren't. And issues of grief, of the picture that people drew by themselves with their spouse, of their own personal identity, and a loss of innocence. And above all, it's also a couple's issue. And I always say, and I know Bat-Sheva and Atara have heard me say this before, nobody is married 50 years before their marriage hits a fertility issue. I don't know, they could be married 3 months, 6 months, 5 years, 10 years, but nobody's been married 50 years. And so the bumps that you've navigated before, maybe there have been bumps, maybe there have been larger bumps, but this is like hitting a mountain very, very early on, trying to figure out how to communicate with each other, how to navigate together, how to cope together. And the issues of privacy versus support, if your privacy wall is up so high that you can't get any support, you have to navigate together how you're able to move those issues, how to handle secrecy, privacy, shame, identity, and communication. And also how to navigate Mikveh and your physical relationship. So that's kind of an overview. And we'll get back to different pieces of that, but I'm going to pass it back.
Yeah, so there's no way we're going to be able to cover every aspect of the treatment experience, but we're going to, I think, do an overview of some of the most salient issues that come up. And with that, I'm going to ask Bat-Sheva, could you please, let's start out with a discussion of treating male infertility and the main issues that come up there. Bat-Sheva, could you give us a medical background as to what are perhaps the most common treatments that might be going on for treating male infertility?
Sorry, I muted myself for my cough earlier. Absolutely. So, one of the things to start off with that I think is often overlooked is how common male infertility is. People tend to think of infertility as a women's issue. The world tends to think of it as a women's issue, meaning I got my training as in obstetrics and gynecology, right? So I fall under sort of the rubric of women's health. And yet many times I'm treating a couple, and many times that issue is not necessarily with the woman. It may be with the man. Male infertility accounts for about 25 to 33% of all infertility cases. And sometimes there can be two issues going on. It is not uncommon that I will have a couple that comes to see me where she says, oh, my periods are irregular. That's clearly the problem. We're going to treat that. And ultimately, we actually uncover that there's also a male component. And so it's much more common than people realize. And I think men have a very difficult time. I'm sure Karen can touch upon this from an emotional standpoint, because the world has led them to believe that pregnancy and fertility and all of these things are really a women's issue. And now all of a sudden the kind of focus becomes on them, and it becomes a real challenge sometimes. In terms of treating male infertility, it really depends on what's going on. And it's almost as a result of the fact that so much of infertility treatment lives under the rubric of women's health, there isn't a lot of research and new technology that's come out in terms of treating male infertility. When we look at male infertility, we have to kind of look at it through the lens of what's going on. So a semen analysis, when we look at sperm, first we want to know, is there sperm or is there not sperm? If there's no sperm, that becomes a much more impressive issue that needs to be dealt with in a more urgent fashion. And the question is, if there's no sperm, is it because there never was any sperm? And is there some genetic issue involved that isn't allowing sperm to be generated? Is there a disruption in the communication between the brain and the testicle, and the brain is just not stimulating the testicle to grow new sperm? Or has the testicle completely failed and it's no longer growing sperm at all? All of those things can be pretty significant and sometimes irreversible. And so if that comes up, that becomes a really significant issue. The other thing that may be happening is it could just be a mechanical blockage. The vas deferens can be blocked for a variety of reasons, and perhaps there's plenty of sperm, they're just kind of stuck, and it just needs to be aspirated. So the treatment for that is going to depend sort of what's causing it. And if it's something catastrophic, there may not be a cause. There may not be a treatment. If it's something less catastrophic, there is sperm being generated, but there's very, very little, or it's stuck. It may be a surgical technique that's needed in order to aspirate sperm that can be used in an IVF case, for example. Now that's an extreme. Let's become a little less extreme. Let's say there is sperm, but there's not a lot of sperm. Why is that? It could be some of the same reasons. Sometimes it can be genetic. Oftentimes it's more ethereal, has a lot to do with this communication between the brain and the testicle. And that's very sensitive to things like smoking and drinking and sleep and weight gain and weight loss and all these factors that kind of play into lifestyle. And what's interesting is we often think about women altering their lifestyle in terms of preparing for pregnancy. And the truth is that from a fertility standpoint, a woman's lifestyle actually has very little impact on her fertility. But for men, actually, the lifestyle has a tremendous impact on their fertility. Not only that, it takes about 90 days for new sperm to be developed. And so any lifestyle modifications are going to take about 3 months before you actually see any influence. So some of the treatments may be lifestyle. There could be medical medications, right? If the hormonal levels that stimulate sperm growth are low, sometimes we can give medical supplementation to try to stimulate the sperm to grow further. Then if there is sperm but it's low, sometimes we can do treatment that really enhances the ability for the sperm to meet the egg, not only just to improve the production of sperm, but actually improve the possibility of pregnancy with something like an IUI or an intrauterine insemination. That allows us to take a high concentration of sperm, or as high a concentration as we can get, into a small volume. And normally, when you think about it, when a couple is together, in the ejaculate, there may be tens of millions of sperm, and probably 90+% of it is going to get lost along the way. And only 1% of it is going to make it close enough to potentially fertilize an egg. When we take an IUI, what we're doing is taking the entire sample of sperm that comes out. We're taking all those tens of millions and we're concentrating into a tiny little volume. We put it in a little catheter. We place it through the cervix into the uterus right around the time of ovulation. So we're getting tons of sperm very, very close to where they need to be, in an attempt to really try to make sure that if there are any sperm that are able to reach the egg and fertilize the egg, that we're getting as many there as possible. Sometimes the sperm, they don't swim well, the motility is poor, the morphology is poor, that's the shape of the sperm, and sometimes that responds to IUI, but sometimes it doesn't, meaning if they can't swim, even if you put them really close to the egg, it may not be enough. And so sometimes the next step is to think about doing IVF. And people don't think about IVF as it necessarily a treatment for male factor, but actually it's one of the best treatments for male factor, because when we think about trying to conceive in the body, we need millions of sperm just to reach a single egg. In the lab, all I need is one single sperm for each egg. And we can do something called intracytoplasmic sperm injection, which sounds like super sci-fi, or what we call ICSI, where we literally take a single sperm and we directly inject it into each egg. So we're really maximizing the possibility of fertilization. And so we don't often, or many people don't often think about IVF as a treatment for male factor, but it's really one of the best treatments for male factor in terms of the goal of conceiving, because not only can you potentially conceive with single pregnancy, the goal you can sometimes achieve multiple pregnancies because you can create multiple embryos that you then freeze and save for the future. So if there's a real significant catastrophic male factor that may not be altered with lifestyle or medications, it may make sense to look at IVF as an opportunity not only to conceive now, but potentially conceive later. That's a brief. There's some other subtleties and more specifics, but that's kind of the basics when we think about treatment of male infertility.
Thank you so much, Bat-Sheva. And I think one of the issues that is we're very acutely aware of is, let's say in most cases, even if it's just the male who is the patient, it isn't, meaning it's the couple. And that's something that we're very acutely aware of. To reflect for just a brief time on some of the halachic issues that come up. So in the diagnosis talk, Lori Novick set up very well, and I really encourage you to go listen to that talk. She discussed the general approaches in terms of whether any kind of treatment would be a violation of shichvat zera levatala, whether it would be considered wasting sperm. When sperm is procured in a way, semen is procured in a way that is not directly through intercourse. And generally, this is a topic that has tons of halachic background on it, but generally the approach is, certainly Nishmat's approach is that all of these activities are being done not for destructive purposes, but rather to build a family, in which case, done in the proper way, it would not be considered a violation of spilling seed. In fact, it's quite the opposite. And additionally, one of the other issues that comes up with male treatment of male infertility is that if there is some kind of surgical intervention, then the question of whether we're violating the isur, the prohibition of pitsua daka, of crushing the testes, which impacts the ability to marry. That's an issue that comes up in discussion amongst our poskim. Bat-Sheva, before I tell the answer on that one, if you could explain, is that a procedure, or any of the different procedures, because there are many, would any of them cause any kind of permanent damage to a male to the testicles in that kind of situation?
So, I mean, any procedure has a risk of complication, but as a matter of recourse, generally, as far as I know, the vast majority of these procedures, especially now, the move has really been to be minimally invasive. And so typically these procedures don't cause permanent damage. And the truth is that the testicles, if you're taking someone to a procedure, there's already damage there in some way, shape, or form. The major procedures that we're talking about, so one would be, let's say, a varicocelectomy, right? A varicocele is a engorged blood vessel that surrounds a testicle. And the increase in blood flow and turbulence of the blood flow and the increase in temperature can sometimes affect sperm. And sometimes they remove the varicocele. Now that's outside the testicle. And so I think there's a little bit more of a comfort. They're not actually entering the testicle necessarily. But then there are other situations in which they surgically are entering either the tubing of the testicle, like the vas deferens, because there's a blockage and you're trying to aspirate sperm above it, or you're trying to aspirate immature or less mature sperm from within the testicle itself. And sometimes that can be less minimally invasive. Sometimes there's significant incisions and searching that's done throughout the testicular tissue, sometimes under a microscope, where you're really looking through, let's say the testicular tissue might be the size of a golf ball, and you're looking for multiple microscopic, literally like needles in a haystack. And so there can be a large incision that's made through the testicle in order to do that.
Okay, and so there might be the incision, but generally, does it heal? Or again, as all things being equal, it heals, yes or no?
Yeah.
Okay, so in which case, that is kind of the basis for the halachic opinions, like Rav Moshe Feinstein, Zecher Tzadik Livracha, who held that if it's not going to cause him not to be able to procreate, then it's not considered pitzua daka, in which case these procedures would be permitted. Karen, your turn. Let's talk about the psychological aspects of treating male infertility.
So I'm actually going to start with the linguistic aspect because it fascinates me, and I'm like up in arms, but have nothing to do about it, that to father a child in the English language means to give sperm to create a child, right? To conceive a child. And to mother a child means to nurture and to raise, is like the long, years and years and years of parenting. And I think that's a piece, it kind of symbolizes what part of the issue is in terms of male infertility, is that it really, hits at at many men's sense of masculinity. There's often a sense of shame, like Bat-Sheva said, society and historically for sure. It has always been seen as a woman's issue, fertility. And so it really, it's a very strong wound to a man. The other thing that you mentioned, of course, is that the woman often continues to be the patient. So yes, Bat-Sheva just described a heck of a lot of procedures, but the majority of time in fertility treatments is the woman tracking everything, taking medications, being the literal patient for IUIs, for IVFs, for medication, for everything that goes on, short of all the things Bat-Sheva just said. And that creates two dynamics. One, it really creates an issue within a couple of, she's going through this because of me, right? Even though there isn't a lot of control about this, it creates a communication issue. A lot of the men I speak to, when let's say it's a female factor, they're like, no, I'm here to support her. I'm here, whatever she wants to do, I'm here to support her. This is my role. And there's a lot of comfort in being able to take that role. And it's a little bit more muddled when it's a male fertility issue. And like Bat-Sheva said, it can also be a both. It also, stereotypically and research-based, it really comes out that men seek counseling less. They often engage in more avoidant coping mechanisms like denial, distancing, and withdrawal. They don't necessarily want to talk about it. There's a privacy issue. And so a lot of men and couples I've seen don't want the woman to tell anyone it's a male factor issue. She can talk about herself, but not him, which creates an issue within a family, within their own coping mechanisms. I read something a long time ago that said, two people in a couple usually cope differently, and differently doesn't mean worse. it means not the same. So it's often reminding couples that each one of you is going through things. There's a husband, there's a wife, and there's a marriage that's going through this, and trying to keep your eye on all three at the same time, which is like really challenging. And so, you know, and then I also think just religiously, what is it for a man to talk to his Rav about a fertility issue or a sexual issue or things that are tied into procreation altogether? It can be very uncomfortable. So there are often not a lot of places where he can feel comfortable talking about this. And so it kind of pulls on all aspects of it.
Yeah, I'll add that I think particularly in the Orthodox community where there's so much discussion around Shechvat Zar Levatala for like so much of early, let's say, adolescent and adulthood. And that there's an element of shame around sperm and ejaculation and all of these things. And all of a sudden, it, you know, especially in Orthodox couples, grappling with this idea of male infertility opens up like a whole Pandora's box.
Well, and I was going to say, the other part of that Pandora's box is the idea of pru-urvu, which is in the general world, whatever you want to call that, men often are willing to stop treatment earlier than women are. But when you have a pru-urvu incentive or commandment that really has you push forward, and then what that's like for your wife to continue to be the patient because of your mitzvah of pru-urvu adds to it. I'm sorry, Bat-Sheva, go ahead.
No, that's perfect. I was going to say, you know, when I compare my patients of, you know, different, where they're coming from different backgrounds, the men who have male infertility in the Orthodox community tend to struggle much more, in my experience, because of this. It's just not something that's spoken about. And it's not, you know, there's still this element of kind of, we're less taboo talking about fertility in general and infertility, but male infertility is still taboo.
So you've, sorry, there was just a mosquito. You just kind of opened up one of my favorite topics. I'm going to try to not get into so much, but the question of whether a male is required to go through fertility treatments in order to fulfill the mitzvah of pru-urvu. A decade ago, 2 decades ago, the question was, do you fulfill the mitzvah of pru-urvu if you do fertility treatments? And now the conversation is, can you, right? Do you, can you not, right? Or is there an obligation to avail yourself, or is the mitzvah of pru-urvu only through natural means? And that's very complicated when the woman is involved, where there might be the more, you know, she may not quit as quickly from treatments that might not be working, but at the same time, you know, she's a part of fulfilling his mitzvah, and that's a very complicated dynamic. But we're running out of time, so we're moving on to the topic of female infertility. And I'd like if we could start out with a discussion of ovulation and the different treatments that are available to treat any kind of disruption in ovulation.
All right, I assume that's towards me.
Yes, sorry.
Okay, so ovulation induction. This is probably one of the most common things that we see. Ovulation disorders like polycystic ovarian syndrome or ovulation dysfunction is the most common endocrine disorder in young women. So it's super common. It's very common in the Orthodox community. I don't know if that's just because there's a genetic predisposition or because it's more common in young women, and in the Orthodox community, there's lots of young women trying to conceive. But it's just very, very common. And so issues like, let's say, polycystic ovarian syndrome, PCOS, or ovulatory dysfunction that's kind of outside the specific diagnosis of PCOS, is often a disruption in the communication. Before we were talking about the communication between the brain and the testicle. Now we're talking about the communication between the brain and the ovary. In most ovulatory disorders, what you have is an ovary that is chock full of eggs. They are ready to go, but there's so many of them that the message from the brain to the ovary is kind of getting diluted amongst all the eggs that are present, and there isn't really an opportunity for one egg to kind of take the flag and run with it and push the cycle forward. And so you end up with these long stretches of time where there is no cycle, or there's lots of starts and stops. That's kind of the classic PCOS or ovulatory dysfunction picture that you see. And those are the women who are going to respond the best to ovulation induction methods, because those medications are meant specifically to target this issue. And so what ovulation induction medications do is they enhance that communication between the brain and the ovary. And so the kind of first line treatment are oral medications. There's two predominant ones that are used. One is Clomid. Clomid is an oral medication that lots and lots of people have heard of. It's been around for decades. It enhances the communication between the brain and the ovary by telling the brain that it needs to kind of rev the ovary up a little bit more. It's very safe. It has some side effects, but typically mild. They typically are very limited to the few days that people are on them. And so it's a very, very widely used medication. The newer medication on the market is a medication called letrozole. It works very similarly to Clomid, but in a slightly different way. It tends to have slightly less side effects, and it tends to have slightly higher pregnancy rates. So we might say, oh, letrozole is like the perfect medication. Why is anyone using Clomid? In the frum community and in my niddah observing patients, I actually try to stay away from letrozole as a first-line treatment because it can cause staining. And lots of people don't recognize it and I didn't recognize this until I started treating a lot of Orthodox patients, because we kind of grow used to oh, this is the better medication. But what happens is, and in my non-niddah observing patients, I don't hear about the staining because it doesn't really matter. But in my Mikveh patients, it's a really big problem, because all of a sudden you've made this person ovulate, but now they're not going to get to the Mikveh on time because you also made them stain. And so I typically, then when I do choose letrozole, I have to be a little bit more careful. And there's a few other things that we can do. But the typical way we use letrozole or Clomid is you take it for 5 days in the beginning of the menstrual cycle, or at a time where there's no menstrual activity. And 5 or 6 days later, you kind of check on, and you expect ovulation to happen around day 12 to 13 since you started the medication. They're very successful most of the time. And if they're not, then it's time to reevaluate and kind of move on to something else. The next typical thing that we use for ovulation induction is gonadotropin injections, which sort of skip the brain altogether. You give the direct stimulation to the ovary, and you do it with a low dose. But the trick here is that because the brain's not involved, we as the doctors have to act as the brain, and we have to adjust the medications every few days to make sure that we're getting the right dose, not too much, not too little. So it's much more intense. In addition to having daily injections, it's just a lot more visits, a lot more manipulation. But can also be very successful if done kind of in the right circumstances with the right type of patient and the right type of monitoring. And all of these treatments are going to get patients to sort of what I call the natural pregnancy rate. Right? The natural pregnancy rate is somewhere between 1 in 4 and 1 in 6 couples every month are going to conceive in totally healthy, fertile, regular cycle couples. So when you have a situation where the only issue is that she's not ovulating regularly, if you induce ovulation, the pregnancy rates are going to be about what you would expect for a natural cycle in somebody that age. So 1 in 4, 1 in 5, something like that. We often use these ovulation induction methods in other areas of fertility treatment, not just in women who don't ovulate regularly. Part of that, there's a variety of reasons. Sometimes as women get older, we want to try to encourage more than one egg to grow because many of the eggs may be of poor quality. And so if you can induce more than one egg to grow, then the likelihood that one works is higher. And so we sometimes use these medications in that way. Sometimes we use these medications because we're doing an IUI for male factor, and we want to time the cycle properly so that we get the IUI done at exactly the right time. And sometimes we use them because they're relatively easy and relatively inexpensive. And if we don't have an idea, we have a situation of unexplained infertility where we don't have an obvious cause, but we know that something's not working quite right, we'll start with the least invasive, least aggressive approach, which is often ovulation induction, and try that for a few months. And if that doesn't work, we move on to something else. So it does find its way into all sorts of different aspects, but truthfully, it's geared specifically towards the women who are not ovulating regularly.
So just a quick note on issues of staining. I will mention that If a physician has decided letrozole is the best course of action, or any of the different methods are causing any kind of staining, that's where asking a specific halachic question and evaluating your specific situation is quite critical. There definitely is a range of opinions in terms of staining during Shiva Nikiyim and how to relate to that, and whether all bedikot are required or are there fewer that can be done. And so I first of all encourage everybody to take a look at a very informative 10 Talk over in our 10 Talk area of this of our conferencing platform, where Yoetzet Halacha Stacy Goldman really just lays out the background information as to the different issues of tamim, of staining. And also on yoetzot.org, we have descriptions of this as well, or talk to your local Yoetzet Halacha or rabbi. So many different ways to make sure that you're asking specific questions to make sure you're not missing ovulation, especially if you've gone and you are using different medications to get ovulation going in the way that it needs to. So that's a word on that. Now, okay, our tough topic now is the discussion of ovulation before mikveh. Now, notice, I personally try very hard to call it ovulation before mikveh. I do not like the term halachic infertility. The reason for that is because, yes, there are cases, I'll start there. There are cases where there are absolutely no medical issues, and the only reason a woman is missing the mikveh is because she's keeping the halacha. However, Bat-Sheva, I'll call on you in a moment to explain to us kind of the background of that, because what I've seen and what my colleagues have seen, this is not a very highly researched topic. I believe there's maybe 2-3 studies of this topic, but what's been, and so maybe you've heard, 20% of women face this issue that they're ovulating before mikveh, but a lot of things have not been taken into consideration. For example, whether a full halachic discussion has happened to make sure that a woman is getting to the mikveh as soon as possible. I can attest personally that in many, many cases, a woman has been stringent upon herself in all of these laws, and therefore she is not getting a hefsek tahara very early. And this is a situation where we would look for many different leniencies in order to get a hefsek tahara as early as possible, in order to get through Shiva Nikiyim. And so that is step one. And, you remember before Shtisel, I guess a decade ago, remember Strugim? And there's the scene where I think her name is Yifat, right? And she is taking Clomid and she's crying and she's like crushing the pill. And I remember watching that and saying, you need a Yoetzet. You need to talk to somebody. Why did the rabbi tell you? In that case, that's what I believe the storyline was. Why are you taking Clomid before figuring out, are you doing everything halachically possible? Additionally, it wasn't very clear that she had any kind of workup to figure out, is there possibly some kind of medical issue? So Bat-Sheva, talk to us for just a few minutes. When is a 21-day cycle normal fine? When is a 21-day cycle, right? When is a day 10 ovulation or a day 9 ovulation? When is that totally healthy and completely possible to conceive? And when is it not?
Okay. So I'll start by saying I see a lot of women who come to me with this issue. I mean, I have a large Orthodox population of patients. This is something that comes up very, very, very frequently. In a good portion of my patients, a pretty reasonable portion of my patients, it's just like Atara described. It's a situation in which someone's not getting to the mikvah until day 14 or 15. And many times that's a result of their being overly stringent and not asking the right questions. Sometimes it's somebody who's having really prolonged bleeding, right? So that's a medical issue and an area that can be addressed. Well, I should take a step back. My very first question when someone comes to me and says, okay, I think I'm missing ovulation because I haven't got to the mikveh yet. My question is, when are they going to the mikveh? Are you going to the mikveh on day 12, day 13, or are you going to the mikveh on day 14, 15, 16? So if it's day 14, 15, 16, then that's a question of not necessarily ovulation being too early, but the mikveh being too late. And why is the mikveh being too late, right? Is it because they're bleeding for so long that they can't get a hafsek? And is that real? Like, meaning they seriously do have a long period that needs to be, could that be addressed medically? Many times it can be. Or does that need to be addressed halachically? So that's number one. Number two is, let's say they are going to the mikveh on day 12, right? And they're ovulating on day 10 or 11. Now the question is, why? Why is that? And one of the biggest concerns, and this is true outside of the Orthodox community too, it just becomes a little bit more clear when you're so focused on the days of your cycle. Short cycles, particularly cycles that are shorter than 24 days, is an early warning sign of diminished ovarian reserve or a drop in ovarian reserve, because women are born with all the eggs we'll ever have. Over time, we lose them. As our ovaries become depleted with eggs, our brain is working much harder to try to get the cycle to go forward. Remember, in order to drive the cycle, there's got to be an egg that kind of takes that flag and runs with it. And so it's harder when there's fewer eggs around. And so the that pressure to have a cycle is a little bit higher and a little bit faster. And so what starts to happen is that the cycles actually start to overlap. So you get selection of the next egg for the coming cycle a little earlier than you would have. And it's actually before that period comes. So you get this overlap, and then that egg is ready only 9 or 10 days later because it already started growing before the period even came. That's a very common phenomenon that we see in women in, let's say, in their late 30s, early to mid 40s. As they kind of bridge towards the perimenopausal period, you start to see what we call loop cycles. They overlap each other. And then that ultimately, over the course of a few months to years, leads to what we call lag cycles, where you start dropping cycles in between. And then you go 2 or 3 months without a cycle, and then you get another cycle, and then ultimately the cycles go away because you go into menopause. So a young woman who has a short cycle, especially if it wasn't always that way, meaning it used to be longer and now it becomes shorter, by and large, that becomes a red flag for other fertility issues, not related to mikveh. And so even my colleagues who work in communities that have no Orthodox presence, that's a red flag to them if someone comes to say, oh, I used to have a 28, 29-day cycle, but lately it's been more like a 24-day cycle. So that's a concern. And so when I hear that women used to be able to go to the mikveh on time, but now are ovulating earlier, or their cycles are much shorter, to me, I worry that that's an early sign of diminished ovarian reserve. And we do some testing as a result of that. And sometimes an appropriate treatment may be not only just delaying ovulation, but also trying to enhance ovulation with medications like Clomid, or trying to improve the chances that pregnancy will occur, not only because of timing, but because there's other stuff going on. But there is a percentage of patients that I see that it's really, they've always had a 24-day cycle. It's never been different. They've always had a short cycle. They have a totally normal ovarian reserve. That's just their cycle, just the way their body works, the mechanisms and the cyclicity of their brain. And sometimes, they've asked their Rav, they've asked their Yoetzet, and this is sort of what the situation is. And then the question is, how do we address it? And Karen, I know will kind of touch upon sort of the emotional aspects that come to the fore when you start talking about kind of medically treating somebody in order to adhere to get pregnant within the confines of the laws of mikveh. But one of the things we can do is, what I often try first is actually a protocol that came out of an Israeli study many, many, many years ago, where we can use estrase, which is just technically like a natural hormone. It's estradiol, which is naturally produced in the body. And what estrase does is fool the brain into thinking that it doesn't need to start picking up the egg yet. And so it slows down the menstrual cycle it slows down the selection of the egg and slows down the process of ovulation. And then you wean it off as you get closer to mikveh. And so you don't necessarily need to use fertility medications in these types of situations where it's really just about the cycle. You can try something a little even less aggressive, less invasive than that. And that can be very successful. And if it's not, then typically that means there may be other underlying issues going on as well. So the mikveh, ovulating before the mikveh can be the canary in the coal mine for some other issues. And so I agree with Atara that I try to shy away from the term halachic infertility, because it really isn't always the halacha that's getting in the way of conceiving.
And before I ask Karen to talk about that emotional experience when it actually is happening, I really just want to say, for any case where it really is halachic infertility, where that is the only barrier, statistics don't matter. All that matters is your particular case, and it's painful. And I don't want to minimize that pain. In fact, I want to really validate that pain. But I think that there needs to be context so that people are asking the right questions, doing the right testing, and asking the right halachic questions in order to really assess the situation properly. Yes. Karen, go ahead. What do you want to add to this discussion?
I guess there are two things I want to add. First of all, I just want to balance out the female factor, male factor part from the mental health perspective. Women tend to have more depressive and anxiety symptoms. A lot of women also want to discontinue anxiety or depression medication or therapy. I have a lot of people, as they say, I've been taking medication, I've been going to therapy, but now I need to put all my money and I don't want to be on medication during treatment. So I'm going to stop all of that, which is probably not the best idea. I never recommend that, right? Stay in therapy, not just with me, but with anybody, because you need more support, but don't get rid of your supports and ask the questions about medications. If you're on antidepressants or anti-anxiety medications, is probably also not the best time to go off. And I can't tell you how many people do that without talking to their doctor. And so it's extremely important, if you are going to change something about your medications, that you have that conversation, because that's supposed to be done with a doctor. But in terms of the other factors, there's a very big sense of it's my fault. It's my fault that we can't have children. Women tend to, and I know I'm speaking in such generalizations, but women tend to visualize a lot of this stuff more. If you ask, many, many young women, tell me what you would want for your wedding, right? They may give you like an hour and a half discussion. They may give you a 10-minute discussion, but many of them have thought about it. If you ask many men at the same age, tell me what you want at their wedding, they're like, I don't know, right? Same with parenthood. Women tend to visualize these more. And so it's not just about the vision, it's about kind of that future vision. And it's very, very hard to stay in the present. And the present is very uncomfortable, because everything is kind of crashing in the present, and your lack of control and your lack of ability to do something, and you're all of a sudden doing a medical procedure, and these women are living very, very microscopically. How big are my follicles? What day am I on, right? And so you're living very microscopically in a process that you're not really wanting to live very microscopically in. And so I do try to take my patients very slowly to stay in the present. Even though it's very uncomfortable. But going into the future is often going down a rabbit hole. And then it's very difficult. Staying off social media, I cannot say it enough, or limiting social media, like just take it off your phone and have to purposely go on your computer. But it is a flood of stimulation all the time. And for women who have miscarried, trying to conceive post-miscarriage is extremely difficult. It is the most vulnerable feeling to be doing something that and I have a lot of patients that are like, I don't even think I can hope. And the truth is, of course they're hoping, because they wouldn't be doing treatment if they weren't hoping, because nobody does that, right? You don't do it if you absolutely think it's hopeless, but it is so uncomfortable and so vulnerable to do that. And so there's it's not, those aren't like specifically female factor, but they all kind of tie together. In terms of the idea of what it's like to conceive in a doctor's office, again, the living microscopically, it becomes a part-time job. So you now have whatever life you had, which was probably very full, and now you're adding this part-time job that the husband probably doesn't have, at least in the same degree. Some couples really do try to split it. He'll do all the appointment making and she goes to the appointments. It's kind of hard to really manage someone else's schedule. Or if she's doing all of this, then he will pick up some other things around the house. But to try to really balance within a couple, talking about it, but having times when you don't talk about it, that it doesn't become everything all the time. The idea is that, and especially I think COVID has made this worse. And a lot of the fertility clinics, husbands have not been able to come for treatment. Certainly at the clinics that I work at, they're still not allowed to come in for almost anything. And so a woman is getting pregnant without her husband. Like he could be, far away. He could be away for months and she can get pregnant without him, and it doesn't feel so connected, not just emotionally, but he like literally isn't physically present. Whereas even pre-COVID, most husbands were coming for an embryo transfer or for an IUI or something like that. And so I think it's really exacerbated that split of how are we conceiving together, and what is this like to be doing this in a doctor's office? And so I think those have really pulled on people in a very particular way as to how lonely this process can be, and to try to, I always talk to couples about, like, you don't need to be on the narrowest road together. You need to be like at least arm's distance apart, but not further. If you can't hold hands in an emotional sense, you're too far apart. If you're glued side by side, it's a little claustrophobic. So somewhere, but you never want to be further than being able to hold hands, close or distantly. Otherwise, you're going to definitely need to get some assistance with that and try to stay on the road together.
Thank you for that, Karen. Okay. In the interest of time, to keep to our hour, I want to very quickly mention that there are anatomical issues which could impact and need to be treated, which are basically mainly treated surgically. Am I correct on that one? Yeah. And I think I want to move over to discussing the two main ways, if it's not just treating ovulation induction, if we're talking about IUI and IVF. So Bat-Sheva, 30 seconds, IUI.
Okay. The goal of IUI is generally to try to optimize every aspect of a natural, air quotes, conception, right? So we often give the woman medication to try to boost ovulation, to get the timing perfect, right? We want to make sure we know exactly or roughly when we think she's going to ovulate, and have that whole ovulation process try to be as controlled as possible. And then we're going to boost the sperm aspect, right? We're going to take, like I mentioned before, tens of millions, hopefully, of sperm and put in a tiny little amount in this little catheter that we place through the cervix into the uterus, right near where the eggs are going to come out, so that you're getting lots and lots of sperm right there at the right time. And that allows, conception is happening in the body the way it normally would, except we've just kind of controlled all the other aspects in order to just increase the chances that it happens.
30 seconds, pretty good. So from a medical perspective, from a halachic perspective, the issues that come up, again, once we've dealt with the whole shichvat zera levatala and we've decided this is not levatala, certainly there still are different methods of procuring that sperm. Again, I get to reference Lori Novick took care of that topic for us back in our diagnosis talk, which is very, very important to really review the different options of how to get the sperm in order to do this method. And one of the issues that very much comes up is both with IUI and IVF. By the way, in terms of the post-scheme, I love tracing the journey, the historical journey, watching how as the medicine improved and as the medical options were more reliable and as we trusted the doctors to be doing ethically better treatments and not just doing random things to get women pregnant, that we watched the halacha evolve as well as the reality change. The halacha stays the same, but as the reality changes, the halacha responds differently. And therefore, to see that evolution is pretty wild. But you might have post-scheme who were more comfortable with IUI than with IVF, because with IUI we're taking all the zera, we're taking all of it, and we're putting it in the woman. Whereas with IVF, perhaps not all of it. Right? We're choosing. We're not taking everything. And therefore, one of the methods that might be recommended is fine. Anything not being used right now, we can freeze. And therefore, it is kind of in the process of conception and fertilization. So, but in terms of IUI and IVF, one of the biggest issues that comes up is, are these procedures permitted when a woman is in niddah? And on this, again, it's unbelievable to look at all of the shutim, the responsa literature on this, but the bottom line is that the idea is that only the active intercourse is forbidden during niddah, but that doesn't mean that you can't get sperm into or a sperm and an egg into a woman when she's in the state of niddah. There was a debate amongst the poskim as to whether it would be good for a woman to go to the mikveh after what we call niddah de oraita, before niddah de rabbanan, not touch, but at least go after niddah de oraita after 7 days. The decision of Rav Moshe Feinstein was that that's confusing, and that might actually lead to leniencies. That's keeping a stringency that would lead to leniencies. Rav Ovadia Yosef initially said do that, and then he retracted and said don't. So that topic comes up, and basically the bottom line is the consensus of most poskim is these procedures are permitted even if a woman has not yet gotten to mikveh. And okay, so if we can now move on to kind of looking at the stages of IVF in just a few minutes, if we can cover the different medical and halachic issues that come up in a typical IVF round. Yep. So, Bat-Sheva, let's hear from you.
I'll give you one previous tidbit on the IUI aspect and how, about niddah. Like I said, I have a large Orthodox population of patients. A lot of my time is spent kind of orchestrating people's cycles to try to get them past mikveh. Like my staff knows to ask every patient when they're going to the mikveh, and we have it on our chart. So, while I have many wonderful colleagues, many of whom are very, very knowledgeable in Hilchot Niddah, it's important to talk to your doctor about it, because being comfortable having those conversations will make the whole process so much easier. Because sometimes there are things that can be done that can be manipulated without really sacrificing much. So it is worth at least having that conversation, the same way it's worth having a conversation with your halachic advisor. It's having a conversation with the physician as well. Okay, IVF. IVF has several different components. And in this case here, we're kind of, as the physician team, taking control of each process that leads up to conception and maximizing the opportunities at each point. And so this part is happening completely out of the frame of the natural menstrual cycle. So we start by maximizing the egg output. On any given month, there's going to be a group of eggs that comes to the surface. Like I said, the brain is going to naturally select one, and then the body's going to discard the ones that are not selected. What we try to do is use medication to overcome that program and get the ovary to select as many eggs as possible to grow and mature. That takes about 8 to 12 days. We do that with hormonal injections. We teach our patients how to self-administer them. They are the same hormones the brain is using to regulate the menstrual cycle. So it's not like something your body's never seen before. But we do it in a higher amount for a longer period of time. We do have our patients typically come for visits every 2 to 3 days, again, to adjust the medications and the timeline that a woman is on them in order to really maximize how many eggs we're going to get from this process. And that's going to be different for everybody. And so it has to become very individualized. Once it looks like a woman's grown as many eggs as we think she's going to be able to, we then have to remove those eggs from her body in a procedure called an egg retrieval. The egg retrieval is a very minor surgical procedure. It's typically done in the office in a procedure suite, typically with anesthesia. It's the same kind of anesthesia someone might have for a colonoscopy or an endoscopy. We use IV sedation. You fall asleep. You're not intubated. Women are breathing on their own. Now I can say you're not intubated and everybody knows what that means. In the past, I used to have to explain what that means. But it's just like a very, very, very deep sleep. When we do the procedure, we use a transvaginal ultrasound probe and a needle through the vaginal wall into the ovary to essentially retrieve the eggs from within the ovary. There's no incisions, there's no stitches. The whole procedure usually takes about 15 minutes to do. Wake up very shortly after, hang out in the recovery room for like 30, 40 minutes, and then are free to go home. Most women typically are able to kind of go back to their usual lives. I used to say people could go back to work, but nobody goes to work anymore. So now I say go back to usual life by the next morning. And so that's kind of the first piece of the procedure. That's the stimulation retrieval. Then we have the eggs in the lab. Now, just as kind of a side note, women who are doing egg freezing, let's say you're doing fertility preservation, that's where this stops. The eggs are out of the body, they get frozen. For those who are doing fertility treatment and trying to conceive, they fertilize the eggs at that stage. So the eggs and the sperm are brought together in the laboratory. That's the term in vitro fertilization. And that's where the magic happens. Then it takes about 5 to 7 days for the eggs, now we call them embryos, to grow in the laboratory to the final embryo stage, which we call the blastocyst. That's the stage at which the embryos naturally implant in the uterus. It's also the stage at which the embryos can be safely frozen for the future if you have extra. It's also the stage at which the embryos can be tested. Now, in the United States, and this differs a little bit for what's happening in Israel, but in the United States, more and more couples are choosing to test the embryos at this stage to see their chromosomal makeup, because that's the number one reason that an embryo won't work, is as an abnormal number of chromosomes. And so the embryos can be tested and can be frozen at that point. As in the United States, we're doing fewer and fewer fresh transfers. Typically, the embryo creation is getting separated from the transfers going back into the uterus for a variety of reasons, but essentially, in many cases, the pregnancy rates are better in that way. And so we've been really doing that much more frequently. So the embryos get frozen. The woman's body is allowed to return back to sort of a more natural state where the hormone levels were sky high from the retrieval. They come back to a typical state, and then we prepare for the transfer. The transfer either is a natural menstrual cycle or it mimics a natural menstrual cycle. And what we try to do is on the 6th day after ovulation, which would be typically when in a natural cycle, the blastocyst would implant in the uterus. We take a tiny little catheter and we very, very, very carefully place the embryo inside the uterus and hope that it sticks. And 9 days later, we do a pregnancy test. There's lots of variations on that, but that's the basics.
Wow. Okay. And just a very quick laundry list of the halachic issues that come up. And then I want to really give Karen some time to address some of the emotional pieces, and especially since an important question came in our Q&A. But in terms of staining, I already mentioned any staining that might happen as part of the treatment. Please ask questions, ask beforehand, be armed with information in order to evaluate and not have it interfere if it doesn't have to. Shabbat is a whole other hour-long lecture. How do we work around Shabbat? Try to not have any kinds of the pieces that require any malacha come out on Shabbat. Bat-Sheva and I talk about that.
By the way, my embryologists have candle lighting time on their Google Calendar.
Oh, that's beautiful. I love it. That's amazing. I also would like to give a shout out to Extend Fertility for sponsoring our conference. So thank you. And also issues of the injections. We have not talked about that at all in terms of whether a husband, if the wife is in niddah, can he give her injections? What are the halachot about that? I'll give another shout out, and I want people to know about the fertility counselors, about Nishmat's fertility counselors, because each question really is so individual and deserves its own particular treatment. And we spent a year in-depth studying these issues on top of our years of training as a Yoetzet. And not only that, but every 2 weeks, we're continuing to have training. So we spend a lot of time really working on these issues because they're complex. But in terms of injections, yes, there might be a preference that a woman inject herself or have someone who's not her spouse inject. But, sometimes, and this relates to some of the issues that Karen can be a resource for, again, even if couples might want privacy and may not want people involved in this part of their lives, that doesn't mean they're being secretive. It means they want privacy. And there's a very big difference between those two. This might, on the other hand, be a way in which somebody very trustworthy and very discreet and very filled with empathy might be brought in on the situation to help this woman during this time. And that might be a way in which to kind of safely expand the circle if that's what works for this woman, but only if it works for her. And then if those don't work, and if there's a fear of needles, if there's any kinds of issues that might also come up, there are halachic solutions to have, at least at Nishmat. So contact us to have a husband help with this, with the logistics here and the financials. There's so many different issues that could come up. And then I'll just mention in terms of the egg retrieval, that is a needle that goes straight from the vaginal wall into the ovary. Therefore, any blood from that would be considered dam makah. It would not impact a woman's niddah status. And then in terms of the embryo transfer, right, tiny little catheter, which is smaller than 19 millimeters. At Nishmat, we go by Rav Moshe Feinstein's definition in terms of whether a procedure on its own, even if there is no bleeding, renders a woman niddah, and we go with 19 millimeters. I know that that is subject to debate, and there are poskim who go with a far smaller measurement, in which case that is more of a discussion and more of a conversation. But just on one foot, those are the issues that come up in terms of that. So two really important questions that I saw in the anonymous Q&A. I'm going to, one of them was, is about staining during Shiva Nekiyim because of PCOS and going to the mikveh late and ovulating on mikveh day, which might be day 15 or 16, and bringing the decode to a Rav in order to work on this, which is really, really very admirable, and we really commend how hard this woman is working to make this work. I don't know, but Bat-Sheva, any thoughts? And then really, we're going over time. I don't know. Sorry, I mean, we're not stopping anyone else from starting, but we could go all night. But Bat-Sheva, what would you say? Any advice for this woman?
I mean, this needs to be handled, a case like this needs to be handled with a physician who's sensitive to understanding what the limitations are, and a Rav who's understanding what the physical limitations are, right? There's this push and pull and this dynamic here, and it can work. There just has to be a collaboration between the three people involved, meaning the person, her halachic, or the couple, their halachic advisor, and the medical team, and trying to figure out what the best approach would be. And it may be a little bit of trial and error, right? Something might work for one cycle and then not work, or it didn't work the first time. And don't get discouraged. There are treatments. This is like our bread and butter, and it is a slog to kind of get through this month after month, but it is something that can be dealt with.
We're here for you. Talk to us. We want to help. Okay, Karen, I think this question really is going to help us get a lot of wisdom out of you as to more of the complexities, the emotional complexities. Take your time. People can turn it off.
I was going to say, I'm completely torn between Al Regal Achad and taking the rest of the night. So I think I'll split the difference. It's a really good question. Okay. First of all, because it's very, very hard to live life on a tightrope, and your relationships aren't real if you're always living on a tightrope and you're overanalyzing everything you've said, and oh my God, and what if, and how did I, and oh my goodness. People don't generally want to be treated as eggshells. They want to be treated sensitively. So there's a big difference. What you'll see is people kind of running the other way. So like, well, I can't have them over for Shabbos meals because all we do is talk about the school or this or that, or, preschool, or my pregnancy, or everyone else is pregnant, so let's not invite them over. But that leaves people very isolated, right? So the other option, of course, is to invite people and not only talk about that, or to be sensitive and not talk about it, but limit it and make sure you're talking about other things. Someone in my community this year, I presented for the Mikveh Muna Society in Silver Spring, and someone called me afterwards and she said, when we were having trouble, we noticed that every Shabbos meal we went to, we ended up at a table by ourselves. It was me and my husband, because one person was doing the food and all the other people were dealing with the kids. And we literally looked at each other like, I guess we could sit at home ourselves. And so they made a rule that once they had children, one of them, no matter what else was going on, was staying at that table. And if it took a long time to serve the food, it took a long time. If someone had a meltdown and still the food wasn't served, then that's what happened. So, I was talking to a client today, a client actually who was about to do an egg retrieval, and she's trying to balance between, living in the future and hope and being very anxious. And she feels like she's on this tightrope. And we work very hard with not walking on a tightrope, but a balance beam, right? Like there's a little more width to a balance beam, right? Or and that it's kind of doing both at the same time, being sensitive to someone, but not avoiding topics, not avoiding avoiding the most insensitive things like, oh, you're so lucky you don't have yeshiva tuition. Avoid things like that. But you don't have to, you want to navigate and take a pulse of the room. And how is the friend responding? And how do you talk to a friend and say, listen, I know what, I just want to check in with you. Do you want to talk? I'm really here to listen if you want. Check in with people, answer, be available to people without bombarding people. And I would just add to that, not just the friend question, but the family question, because I hear from so many people that grandparents often only care about grandchildren. So as long as you have nieces or nephews, the grandparents they're like, and a lot of parents will say this, they go, I don't care about you. I want to see my grandchildren, right? And that's actually very hurtful, I think, to a lot of people. First of all, it's hurtful to people who are parents because they still want to be seen as a person. But if that's going on in a family and one person is having trouble conceiving, they really feel like their family doesn't value them. And so to make sure as people hit that generation to be able to see their child and what's going on for them and to balance each of the children's needs, right? Those who need help babysitting and those who don't, and seeing everyone. It's really, I said this the last time I presented somewhere, we've spent every day, I see people by Zoom or by the program I use, and I start every session like, okay, wait, can you hear me? Can you see me? I see you, I hear you. And I realize that is exactly what we want in life. Can you see me? Can you hear me? And I can see you, I can hear you. And so if you're doing that, then your balance beam just becomes wide enough that you're on solid ground and you're no longer walking on a tightrope.
Okay, we're getting some amazing questions here. Okay, here we go. I didn't manage to create the banner. Here we go. This one is, you know what? As I'm loading up some of the other questions, Karen, could you talk a little bit? You mentioned a little bit before about living in the doctor's office. Is there anything else you want to add to that as I load up some of these other questions?
I mean, sometimes people feel like they're conceiving with their doctor. They become this very trusted person. They can also become a very magical person, right? I mean, no offense to Bat-Sheva, there's a lot of hero worship going on, and maybe it's very, very deserved. And often it is very, very deserved. To be able to help someone conceive is truly miraculous. But then it can lead to tremendous disappointment. And doctors can only do what they can do. And, and I talk to people a lot about percentages, right? Well, the doctor said there's no reason I shouldn't get pregnant, or, he or she really thinks this is going to work, but then they don't get pregnant that cycle. Doctors work in percentages. I can't remember which of you said that before, right? And so we really make medical decisions based on percentages, but we live 100% in what happens, right? So if you take a medication and it has a 5% side effect of X, okay, that's a really great bet. But if you hit that 5%, 100% of you is going to have to cope with that. It's not like 5% of you is going to cope with that. And so learning how to, understand the and everyone understands it, but living it is a very different experience. And so people tend to see their doctors and their teams as very black and white, right? If I get pregnant, they're amazing. If I don't get pregnant, they're terrible. It's not really, it's so fair to do. It's often a displacement to put all that on the medical team, and so it's navigating that balance as well. Shout out to Bat-Sheva.
Let's give this one to Bat-Sheva. Just a quick medical one.
Can the retrieval and the transfer be done in the same cycle? So you can, and that was kind of the classic way we used to do IVF, is that we would do the retrieval. Immediately following the retrieval, we would continue that preparation for the transfer. And 5 days or 3 days after the retrieval, we would transfer whatever embryo we had or embryos that we had. This led to a lot of different things. First of all, it led to a lot of multiple pregnancies, multiple births, because at these earlier stages, we don't always have a great idea of which are the best embryos. So we have to put in more in order to compensate for that. It also didn't allow for this additional testing that has become better and more popular, not perfect, but better and more popular. But probably the number one reason, and the one that I think about most, is that there's been some really good studies that look at birth outcomes. So things like birth weight, preeclampsia risks, preterm delivery risks, that demonstrate that some of these elements of what we call placentation, the way the placenta adheres to the uterus, are very much influenced by the hormonal environment that the embryo or the pregnancy is exposed to at the time of implantation. And following an IVF cycle, the estrogen levels are going to be sky high, meaning a typical estrogen level at the end of an IVF cycle. Well, let's say this, the typical estrogen level around ovulation is like 100, 200, maybe 400 max. In an IVF cycle, minimum, we're talking about estradiol levels that are in the thousands, 1,000, 2,000, 4,000. So you're talking about a 10-time increase in the estrogen that the pregnancy is being exposed to. And what we've learned is that that's not necessarily good for pregnancies. And since the freezing technology, at least in the United States, again, this differs by location a lot, but in the United States, most of the big IVF labs have gotten so good at freezing and thawing embryos that it's not worth the risk of transferring it in a fresh cycle. Now, that's not true for every case. And so while you can do it, it's often not the best method to do it. And so these days, I haven't done a fresh transfer in a very long time. We really try and do frozen transfers, but there are circumstances in which it makes sense to do a fresh transfer.
Okay. Here's another question that came in. Karen, go ahead.
I have to read it. What advice do you give women getting diagnostic workups and getting special tests made for their genetic condition of concern and feel like they are wasting cycles while they wait? I don't know. I don't know if advice is the right word because I'm not a genetic counselor, so I don't know that I'm best suited to give advice for that, right? The piece I can address is the idea of wasting cycles or time. And it is a very difficult thing to come up with, that time keeps passing, and how people cope with the idea that time keeps passing. And it passes like, there are like several clocks going at the same time, right? So there's the clock of your eggs, right? There's the clock of your fantasy of by X number of years married, we are going to have a child. By the time I'm X age, we're going to have a child. There's the X of your social circle, everyone else in your cohort, your friends who got married at the same time, they're all parents, you're not, how that works. So there's the X of, the time in terms of siblings, right? Your siblings start in your mind passing you by. Younger siblings get married, they have children. And so that pressure of time is tremendous. And that pressure of time comes without a crystal ball, right? So if you had a crystal ball and you said, oh, I'm going to have 3 children and look at those 3 kids, and I wouldn't trade those 3 kids for 3 kids that are hypothetical kids, right? That might make it easier, but no one has that at the time. And so just really talking about that, understanding each context that's happening in, trying to live in the present, just super hard. I don't mean to make it sound like it's really easy, right? Oh, live in the present. It's like, oh, okay, Dr. Wasserstein said I should live in the present. I'm all better. Everything feels great now. It's not true, okay? And I really understand that. But working on how you can live in the present while pursuing the future is the road you want to be trying to be on, and how to do that and how to keep bringing yourself back to that. Seeing small doses of progress. So I have a woman who, she's on her 3rd egg retrieval and she feels all those are wasted, but then she goes, but I do know that they've learned something every time they've done it as to what might work for me. So measuring waste, and I don't mean to minimize it in any shape, way, or form, because the goal is not, a good egg retrieval. The goal is a baby. And so I don't ever mean to lose track of that. And so it's small comfort, but to see incremental differences, right? When you're living so microscopically, can at least mark that time as not wasted. Wasted is a terrible feeling. But again, it's really going to be within that context of, but I need to, I'm trying to get somewhere. I'm not really here to enjoy the journey. I do have a destination in mind, and understanding what that is.
So you do kind of know. You said you don't know, but you do. But this is such tough stuff, and that's why I think that's why there are therapists who specialize in supporting couples through their fertility journey.
Well, that's what I was going to say. Is that right? So, like a question with an answer with a 2-minute answer, obviously, is going to be too short. Right? It's a process. And so, originally when I heard the topic, it's like treatment. Well, there's individual treatment, there's couples treatment, there's, support groups. It's a much shorter way to do this talk, because I would have spoken for 5 seconds. But these are all processes, and getting people through an experience of real life, that real life just hits you, right? And you can't see what's coming all the time. And so understanding how to navigate huge bumps along the road, as well as the other little bumps that are going to keep coming and knocking you a little bit off kilter. It's a process, and it's not, it's not an easy process, and it's not always a short process.
Okay. Panelists, we have a few more questions. What is your time like? Is this a question?
We go screen free in my house at 9:30.
Okay. So that's our cutoff? We might be able to beat that cutoff.
I might have some people knocking on my door.
That sounds like that works.
As soon as the knocks come, we end. Or before that, whichever is first. Okay.
Let's keep that perfect.
Okay. So another question that has come up is, what is the difference in terms of method in Israel and the US?
So this is a very, let's say, loaded topic. And a lot of it has to do with kind of the different market forces and technology forces that are at play between the US and Israel. So if you go back 10, 15 years ago, Israel was like the leading edge, cutting edge of all reproductive technology. Israel obviously has a very progressive insurance benefit. The financial aspects of it are extraordinarily progressive, one of the best in the world. And the technology was at the leading edge. However, in the United States, where there isn't as progressive a financial arrangement, and it becomes a real competitive and I mean competitive in the kind of capitalistic sense, right? Every place is trying to have the best pregnancy rates, so they can market to patients who are ultimately in some ways customers. We have the best pregnancy rates, and in the United States is sort of primed for that, because we also have by law, all IVF centers have to make their pregnancy rates public, which is not the case in Israel and in Europe. And people are spending extraordinary amounts of money for their IVF. And so that has led to the development of all sorts of technologies. Some might argue that some of these technologies were introduced too quickly. There's not enough studies for them. It's not clear that they're helpful. There's all sorts of things. But what's happened is that the evolution of the way treatment is done in the United States is extraordinarily fast, because everybody's trying to get the next best thing. Whereas in Europe, and certainly in Israel, the evolution has not been quite as fast. What that's translated to is really differences in the way things are practiced. Now, in Israel, there's a much less of a financial burden and much less of a financial pressure that leads to different methodologies in the way that the treatments are administered. Whereas in the United States, there's a much greater pressure. So, I don't want to get into too much details in terms of the treatment methods, because they're all basically fall under the same rubric, but there's an art to this. It's not only about science. And there's just an evolution to the way these methods have been developed that's very different in some ways between the United States and Israel. And sometimes that reflects it in pregnancy rates, and sometimes it doesn't. You want me to answer the question about letrozole?
Yeah.
Okay. So letrozole, as I mentioned, I'm glad we came back to this because I want to say letrozole is actually an amazing medication and certainly can be used in mikveh observant women. It needs to be done in a way that you're sort of wary of the fact that they can cause staining. It does not always cause staining. There are certain circumstances when it does. The way letrozole works is that it decreases circulating estrogen levels. And what that does is tell the brain it's time to produce more estrogen. So please stimulate the ovary to grow an egg to produce more estrogen. That little drop in estrogen sometimes causes dysregulation or an unevenness in the lining of the uterus. So you get some shedding. And it can be counterbalanced. There's all sorts of tweaking that can be done. But I brought it up because often people are not aware of it. And sometimes doctors aren't aware of it because, like I said, in communities where people are not as sensitive to it and it's not as big a deal, it doesn't come up. They don't call back their doctor and say, I'm staining. What do I do? It's just like, okay, fine. I'll add a little bit of staining after my period. So I bring it up mostly just so that you're aware of it, but not because it's something that I discount and can't use in the Orthodox population. That's absolutely not true.
Okay. Let me just look and see. First of all, just put our event game in. I also would like to encourage people to join us at a special talk. We have the endometriosis talk, and we also have a talk in like a few hours about gamete donation and gestational carriers. It's a really amazing set of panelists. It's Rav Gidon Weitzman from Machon Pua in conversation with Yoetzet Halacha fertility counselor Yardena Bodenheimer, who works for the State of Israel in the Ministry of Justice, and also moderated by Dr. Sahar Wertheimer, who's a reproductive endocrinology fellow. Okay, there is one more question. I think we'll take one more question, which is, can you tell us about ovarian rejuvenation? Does it work, and would you recommend it?
Really going for the controversy. Okay, so ovarian, look, everyone wants ovarian rejuvenation would be the key to all of this, right? So much of, even when fertility isn't, the diagnosis isn't related to age, female age is one of the key factors in fertility success. Because we're always going to be limited by the quality of the eggs that we have to use. And so if we can figure out a way to either slow down the aging process or reverse the aging process, then a lot can be done. So as you might imagine, there's a lot of motivation to try and do this, particularly in women who are undergoing premature ovarian failure, right? So women whose ovaries are depleted of their eggs prematurely. Is there a way we can reverse this process or slow it down? So you can imagine that there's a lot of motivation to try and find the solution to this. There's been some discussion, some trials, a variety of different kinds. I would say up until now, the evidence that I've seen is modest at best. As you might imagine, this is a very vulnerable population, right? Women who are undergoing premature menopause are looking for answers wherever they can find them. Many of them are willing to pay untold sums of money and go through all sorts of physical procedures in order to have any chance of a success. So this is a very vulnerable population that is susceptible to all sorts of vagrancies that can occur, unfortunately, in the medical community. That being said, I think there is some data that looks potentially promising, and there are some studies at very reputable places that are looking into elements of ovarian, what we call ovarian rejuvenation. It's certainly very much in its infancy. It is by no means a magical cure at this point. But I would say there are some things that are promising. And I would, what I generally counsel patients is if there's an opportunity to do things that are treatments that are more well-known and well-studied and have better results. So if there's an opportunity to do something like egg freezing or embryo freezing, I would try that first. and then see, some of these more experimental treatments. But like I said, I think the time will tell in terms of whether those elements that are promising actually come out to something that will be incorporated into treatment.
Okay. Karen, any final thoughts?
The only other thought I really had was going back to your Sugim comment, was that there was this fantastic scene in Sugim about, I think it was Yifat's husband, going for a fertility consultation. And I used to show it when I was doing rabbinic trainings to give people kind of a sense of what it's really like. We've used the words guilt and shame. I hope that we've used them as experiential, that people have them, not that they should have them. Okay, so I just want to make sure we clarify that. That people have lots of emotions. And as I always say, the truth is that we kind of exercise the same 5 emotions. Like when you do a new exercise regime and you come back the next day and you can't move, and you're like, oh my God, I didn't even know I had muscles there, right? And you use muscles that you've never even known you had, right? Because of course there are like a lot of muscles, and we exercise the same 5 all the time. Emotions are the same way. We exercise the big 5 emotions that we're very used to having, and we really ignore all these other little emotions, right? Like Eskimos have a million words for snow. We actually have a lot of words that are very different from each other. So grief and loss and disappointment and hopelessness, and the positive side has as many words too, by the way. And to just really, in order to navigate any complex process, the more you exercise your emotional vocabulary, the more you understand your emotional vocabulary, the better able you are going to be to cope with it. And it's also okay not to always be able to cope, and to then get the help you need. I just want to circle all the way back that it really is okay to be in need of your support system, of your spouse, of therapists to work together with. And I really love how we do this with mental health and halacha and medicine, because they're all very, very much intertwined as to how they work together. And so it's not needy to be in need. It's okay to ask questions of everybody. Ask as many questions as you can and get what you need.
I would like to close with a pasuk from Tehillim that one of my rabbanim, Rav Yaakov Varhaftig, always quotes in reference to his amazement at the remarkable advances that are every day. Ovarian rejuvenation, my goodness. There's a pasuk which says, "V'tachserehu me'at me'elokim." Hashem has given us a tremendous amount of knowledge. We're still not anywhere near Hashem and his infinite wisdom and the intricacies of how he runs this universe. But there's a remarkable ability to say, Ma Rabu Ma'asecha Hashem, as more and more treatments become available to help couples who are yearning for children build their families. So we bless you, that Hashem should answer all of your tefillot l'tova very quickly, and we are here for your journey. Good night.
Good night.